Hey everyone, welcome back to the channel where we break down complex rheumatology topics with clarity and depth. Today's video is all about sulfasalazine, a well-established disease-modifying anti-rheumatic drug, or DMARD, that's still widely used in clinical practice despite the newer biologics and targeted synthetics on the market. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. So, what is sulfasalazine exactly? First approved in the 1950s, sulfasalazine is a compound that consists of 5-aminosalicylic acid, 5-ASA, linked to sulfapyridine by an azo bond. It was originally developed to treat rheumatoid arthritis and inflammatory bowel disease, and it remains a first-line agent in several treatment algorithms today. Let's start with its mechanism of action. In the gut, sulfasalazine is broken down by colonic bacteria into its active metabolites, 5-ASA, which has anti-inflammatory effects in the colon, and sulfapyridine, which is believed to be the key component responsible for its effects in rheumatic diseases. Although its full mechanism isn't completely understood, sulfasalazine is known to inhibit prostaglandin synthesis, reduce inflammatory cytokines such as TNF-alpha and IL-1, suppress NF-κB activation, and modulate immune cell activity, especially T cells and B cells. That immunomodulatory effect is what makes it valuable in rheumatology. In rheumatology, sulfasalazine is most commonly used in rheumatoid arthritis, especially in early disease or mild to moderate cases, psoriatic arthritis, particularly in peripheral joint involvement, and ankylosing spondylitis, although its benefits are mostly limited to peripheral arthritis, not axial disease. It's often part of triple therapy along with methotrexate and hydroxychloroquine for RA when monotherapy is insufficient. And it's an excellent option for patients seeking a non-biologic, cost-effective therapy with a long safety track record. When it comes to dosing, sulfasalazine typically starts at a low dose to improve tolerability. Begin with 500 mg once or twice daily, then increase weekly as tolerated. Target dose: 1000 millismos twice daily, or up to 3 green per day in divided doses for optimal response. It should be taken with food to minimize gastrointestinal side effects, and enteric-coated formulations may also help reduce GI symptoms. Like any medication, sulfasalazine comes with side effects. Common ones include GI upset, nausea, anorexia, abdominal pain, headache, rash and hypersensitivity reactions, orange discoloration of urine and sometimes contact lenses, harmless but alarming for patients, oligospermia in men, usually reversible, and hypersensitivity reactions, which may be severe in those with sulfa allergies. On the hematologic side, sulfasalazine can cause leukopenia, hemolytic anemia, or agranulocytosis, although these are rare. It may also impair folate absorption, so supplementation with folic acid 1 mg daily is often recommended. Monitoring includes CBC and liver function tests every 2-4 weeks for the first 3 months, then every 8-12 weeks, and eventually less frequently once stable. Who shouldn't take sulfasalazine? Avoid in patients with sulfa allergies or salicylate hypersensitivity, those with glucose 6-phosphate dehydrogenase, G6PD, deficiency due to risk of hemolysis, and patients with significant hepatic or renal impairment. Caution is also advised in asthma, porphyria, and during pregnancy, though it's generally considered safe in pregnancy if folate is supplemented. Compared to other conventional DMARDs like methotrexate, sulfasalazine has lower liver toxicity but more GI side effects, is less effective as monotherapy for severe RA, and is more appropriate for peripheral joint involvement in spondyloarthritis, not axial symptoms. That said, it remains a great adjunct in combination regimens and is especially useful in patients with coexisting IBD. And let's talk cost. Sulfasalazine is very affordable, often under $10 to $15 per month with generics, making it a frontline option in low-resource settings or for patients paying out of pocket. Its long-term data, safety in pregnancy, and familiarity among providers make it a solid choice when used appropriately. So, is sulfasalazine worth it? Absolutely, in the right context. While it won't replace biologics in severe or refractory disease, it plays an important role in early RA, mild to moderate PSA, and peripheral SPA, especially when cost and safety are big concerns. With appropriate monitoring and patient education, sulfasalazine is a reliable workhorse that still earns its place in modern rheumatology. If you found this breakdown helpful, don't forget to like, subscribe, and hit the bell for updates. Thanks for watching, and I'll see you in the next one.